We are live.
A very good evening, everyone. Welcome to the iFocus online lecture 429 of the Cataract module. The topic for today's discussion is toxic anterior segment syndrome. For the class today, I would like to welcome the moderator for the session, Dr. Prafulla Kumar sir. Sir has done his MD senior residency in cornea, cataract and refractive surgery at RPC Center, AIIMS, New Delhi. Sir is currently an additional professor at RP Center, AIIMS, New Delhi, and also the current secretary for Delhi Ophthalmic Society. Sir is the chief editor of Ophthalmology Clinics 2, and postgraduate ophthalmology book series. Sir has published over 395 Google Scholar, 156 PubMed index papers, and over 50 chapters in national and international books. Sir has won various awards like the Best Surgical Technique Award from RANSCO, Young Achiever Award at ISCKRS, Ajit Babu Maji Award, and awards for Best Paper in various conferences. Sir is the principal investigator in 2 ICMR trials, 4 PI in 18 trials, including 2 multicentric international trials. Welcome, sir.
Thank you, Gavita.
I would also like to welcome Dr. Gaurav Bharti sir as the chairperson for the session. Sir has done his MBBS from UCMS Delhi. He's done his DO from RML Delhi and DNB from DDU Hospital New Delhi. Sir has worked as a consultant at Shroff Charity Eye Hospital. Sir is currently a senior consultant cataract and IOL services at Center for Sight New Delhi. Sir has been involved in Lyrica pregabalin study. Sir has also been the faculty with Orbis International for short-term training program in Zambia, Africa. Sir is a certified lead auditor by Bureau Veritas. Sir has received certification of appreciation for successful completion of Botswana Cataract Surgery Campaign 3 by Shroff Charity Eye Hospital, Delhi. Sir has completed NABH program on implementation of NABH standards for hospitals. Sir has multiple publications in numerous peer-reviewed national and international journals. Sir also has an enormous experience in cataract surgery and operates almost 30 cases per OT. An excellent mentor to residents, fellows, and even junior consultants, rightly giving him the title of the savior in OT. Welcome, Dr. Gaurav sir. I would like to now introduce the speaker for the session, Dr. Lakshmi Kuniyal. Ma'am is finished her MBBS, MS, FMRF in Retina and Fellowship in FECO and IOL and also FICO. Ma'am is currently the director of Aarogyam Health Clinic, Mathura. Ma'am is a senior consultant at CIMS Mathura. MBBS, ma'am has completed her MBBS from JNMCH AMU Aligarh in 2007. Finished MS Ophthalmology at INM's CHAMU Aligarh in 2010. Ma'am has also gotten her fellowship in FICO in 2011. Ma'am has completed her fellowship in Vitro Retina from Shankar Netralaya, Chennai in 2012. Fellowship in FECO and IOL from Rio Sitapur in 2017. Ma'am has previously been associated with Center for Sight, Safdarjung Center, IQ Hospital, Gurugram, and even the ex-HOD of Nayati Medicity, Mathura. Ma'am is currently a member of DOS, AIOS, VRSI. Ma'am has published various papers in international journals, also worked as a clinical paper reviewer, and participates actively in webinars on various clinical platforms. Welcome, ma'am.
Thank you, Gavita.
I would like to welcome the speaker to please share the slides and begin the class, ma'am.
I believe the slides are visible to all.
Yes, ma'am, they're visible.
Yeah. So first of all, I would like to extend my sincere thanks to Dr. Santosh Anuva sir and to entire iFocus team who has given me this platform to interact with so much esteemed members of the group and the PG students. So in this module of lesson cataract, the topic given to me is the toxic anterior segment syndrome, that is the TASS. It was first described by Nelson in the year 1980 when 9 eyes with intraocular lenses containing residual polishing compound on the surface developed sterile hypopyon. The term toxic anterior segment inflammation was described by Monson et al. In the year 1992. If we move on to the definition of TASS, as we all know, it stands for toxic anterior segment syndrome. The TASS is a form of sterile, non-infectious endophthalmitis. It's an acute, severe intraocular inflammation, which is accompanied by diffuse corneal edema. It usually presents itself within 1 to 2 days of any anterior segment surgery, and it is seen commonly associated with cataract surgery. Besides cataract surgery, we can find cases of TASS after penetrating keratoplasty, even after intravitreal injections, via surgeries, iris-supported phakic IOLs, deep anterior lamellar keratoplasty, and Descemet's stripping automated endothelial keratoplasty. If we talk about the incidence, it occurs either sporadically or it can occur as a cluster of cases. Overall, clusters of 3 to 20 cases of TASS, it occurs several times per year, which translates to an estimated incidence of more than 1 in 1,000 after cataract surgery. Sen Gupta et al. At the Arvind Eye Hospital has reported 60 eyes with TASS from 26,408 cataract surgeries, which gives an incidence of approximately 0.22%. Similar percentage of incidence was also reported in a large case series, which was published by Johnston. Moving on to the pathology and pathophysiology. It is seen as a severe inflammatory reaction in response to the contamination, toxins, imbalanced solutions, medications, or preservatives in the medication. It is a sterile anterior segment reaction. There is no bacterial or fungal infection, although one potential cause of inflammatory reaction may be secondary to bacterial endotoxins. TASS is usually an activation of inflammatory cascades in the anterior chamber in response to the external material or inappropriate solutions during the cataract surgery. And the response is typically apparent and symptomatic 12 to 48 hours after the surgery. So this is how we can understand the whole process. The inflammatory trigger caused by the toxic substances will lead to the breakdown of the blood-aqueous barrier and damage to the iris and trabecular meshwork, which in turn will result in aqueous flare and cells, causing further fibrinous reaction and hyperbion. The overall inflammatory cascade elicited cellular toxicity, free radical damage induced apoptosis, along with the breakdown of blood aqueous barrier will ultimately lead to the breakdown of endothelial cell junctions, leading to corneal edema and its decompensation. Etiology-wise, it is very important to note that TASS is a multifactorial etiological. Bacterial endotoxins or particulate contamination of balanced soil solutions may be found, or intraocular irrigating solutions with abnormal pH, osmolarity, or ionic composition may be the cause. Denatured ophthalmic viscosurgical devices or intraocular medications like antibiotics in the irrigation solution or intracameral antibiotics may be the etiological factor. Besides these, topical ointments or inadequate sterilization of surgical instruments and tubing, inadequate flushing of instruments between cases resulting in the buildup of ophthalmic viscosurgical devices or the presence of preservatives may also lead to the etiological concerns. So as we have already seen, the TASS is carrying a multifactorial etiological factor. So it is very important for us to understand what all possible factors can ultimately lead to the increased incidence of TASS in any of your cases. So first, moving on to the cleaning and sterilization. If there is a presence of inappropriate disinfectant for skin preparation or inadequate time and staff to allow good cleaning and sterilization practices being followed, if there is a presence of residual cleaning agents such as enzymatic detergents, or there is a use of ethylene oxide, if there is a use of lint-containing towels during cleaning, heat-stable bacterial endotoxins from ultrasonic cleaners, water baths, or autoclave reservoirs, if there is a poor maintenance of surgical tools and cleaning or sterilizing equipment, if there is inadequate drying of instruments after cleaning, or the materials used in polishing and sterilizing IOLs, if there is an improper or inadequate flushing of reusable cannulas, handpieces, or tips from phacoemulsification probes or IA probes, if there is a contamination of IOLs and instruments with talc, which usually comes from the surgical gloves, and if there is a presence of residual denatured viscoelastics. So these are the possible etiological factors which may play a role whenever we talk about the cleaning and sterilization practices. Reusage. In this scenario, as we all know that we have to, because of the cost factor, we are more prone to usage of so many things. So we have to be very careful whenever there is a reusage of single-use items, whenever you are tend to use reusable cannulas, you have to be sure that the tap water should not be used for cleaning purposes. Presence of heavy metals and the oxide, for example, degraded brass instruments may play an etiological factor. When we talk about intraocular substances, if there is irrigating solution with inappropriate composition, osmolarity, or pH, if the preservatives used in intraocular solutions, for example, bisulfides or metabolsulfides, if the intracameral anesthetics of inappropriate concentration or containing preservatives have been used, if the intracameral antibiotic with incorrect concentration, pH, or osmolarity has been used, or intraocular dyes with impurities or inadequate dilutions has been used, or if the mitomycin C used has inadvertently has entered the anterior chamber, then these may be the etiological factors associated with intraocular substances leading to the increased incidence of TASS. What are the surgery-related etiological factors? If there is a presence of retained intraocular viscoelastic materials, or there is a presence of residual cortical lens material, in cases of intravitreal anti-VEGF steroids, if there is a use of povidone iodine at the completion of surgery, or if there is a use of ophthalmic ointments have been used at the completion of surgery. We'll be seeing how these factors, they affect the increased incidence of TASS. Even the iodine-related contamination that may also play a role in TASS, where the presence of heavy metals such as aluminum, polishing compounds during manufacturing of IOLs and fluids in hydrophilic IOLs may be the causative factors. So we have seen a huge list of the possible etiological factors related to TASS. Even Sengupta et al. Has also reported that the etiology was not found even after a careful search in approximately 51.7% of TASS cases in the large case series, 60 cases after the uneventful cataract surgery. The major causes which has been implicated in TASS include inadequate cleaning of surgical instruments, contamination of surgical instruments or IOLs, and adverse drug reactions. So just few words about the important etiological factors. As we said, surgical instrument contamination. So let's see how it plays a role in TASS. The American Society of Cataract and Refractive Surgery Task Force suggested that improper cleaning of surgical instruments is the most common cause of TASS. If there is an inadequate flushing of handpiece or the use of enzymatic detergents and the use of ultrasound baths, they were the most common factors involved in TASS, especially enzymatic detergents for cleaning instruments containing endotoxins which are not deactivated by autoclave sterilization. These enzymes are not inactivated by heat of less than 140 degrees centigrade, and most of our autoclaves reach temperatures of around 138 degrees centigrade. Therefore, the ASCRS Task Force on Ophthalmic Instrument Cleaning and Sterilization recommended avoiding the use of enzymatic detergents for ophthalmic instrument cleaning. Even ethylene oxide gas sterilization of surgical tubing lines can result in severe TASS. Moreover, bacterial biofilm contamination of autoclave reservoirs can produce heat-stable bacterial toxins continuously, which can contaminate surgical instruments even during autoclaving. When you talk about intracameral injection, corneal endothelial toxicity and TASS are the potential concerns following the intracameral injection of any pharmacological agent. Drug components, inadvertent dilution with causative agents, preservatives, abnormal pH, or inadvertent use of a balanced salt solution with a low pH can result in cases of TASS. Byrie et al. Reported that the inadvertent intracameral injection of lidocaine and phenylephrine preserved with 10% benzalkonium chloride resulted in severe TASS with irreversible corneal decompensation. Coban et al. Reported that inadvertent intracameral injection of a high dose of gentamicin prepared for subconjunctival injection induced severe TASS and bullous keratopathy. It is also possible that small amount of gentamicin can access the anterior chamber through surgical incisions after subconjunctival placement. Inadvertent seeping of ophthalmic ointment into the anterior chamber has also been implicated in causing TASS. Trypan blue has generally been accepted as a safe and effective method to improve the visualization of anterior capsule during capsulorhexis. When Mathura et al. Reported 5 cases of TASS and Buzard et al. Reported 2 cases after using a generic trypan blue for capsule staining. Higher concentrations and longer exposure times have also been thought to result in severe inflammation mimicking TASS. OVDs, that is the most common of consumers which use in our cases. So we have to be very diligent when we use OVDs. So contamination or denaturation of OVD can be a potential cause of TASS. Contamination by endotoxin during manufacturing was suspected in cases where the OVDs were derived from bacterial fermentation. Traces of OVD residue attached to surgical instruments are sometimes not removed completely during cleaning and can denature to become toxic material. OVD denaturation can occur due to inappropriate handling during shipping and storage. In intraocular lens contamination, heavy metals, as mentioned earlier, such as aluminium, contamination during manufacturing of IOLs that was proposed as a possible cause of massive outbreak of subacute TASS, which happened in Japan. Another case reported 251 cases of late onset TASS, which were related to a particular type of IOL. Besides all these etiological factors, it is also important for us to keep in mind the patient's clinical factors that can also contribute to TASS development. Yaskin et al. Investigated the systemic disease profile in these TASS patients compared to controls. They found the type 2 diabetes mellitus, systemic hypertension, hyperlipidemia, chronic ischemic heart disease, and chronic renal failure were significantly more common in TASS patients. Now we know the definition of TASS. Now we know the etiological factors which can lead to TASS. So now the important thing which comes to mind is the diagnosis. So starting first with the history, you will get an history of acute onset of anterior chamber inflammation occurring 12 to 40 hours after any eventful anterior segment surgery. When the patient presents, they may complain of blurry vision or drop in vision within 12 to 14 hours of surgery. Patient may not complain of any pain or may complain pain from ranging mild to severe. Patient may complain of photophobia. It's very important to perform a thorough eye examination whenever you come across such cases. So evaluation of visual acuity, pupil size and its reaction, thorough slit lamp examination, eye pressure, and dilated fundus examination to the extent possible is very important. In signs, you may find presence of red eye, chemosis, acute severe inflammatory reaction, which may range from anterochamber cells, flare fibrin in severe cases to hypopyon. Corneal edema extends from limbus to limbus, which is seen as a characteristic for TASS. You may have dilated or irregular pupil, which may occur due to iris ischemia. Patient may present with normal or raised intraocular pressure. There may be presence of vitreous inflammation or macular edema. The posterior pole may be difficult to view if there is severe antechamber reaction. So in these situations, it's important that we perform an B scan to rule out any posterior reaction. Both aqueous and vitreous taps, they are sent for cultures to investigate for an infectious process whenever a patient is presenting you with a severe antechamber reaction. The recommended laboratory tests include bacterial culture for both aerobic and non-aerobic, fungal culture. The important differential diagnosis for TASS includes infectious endophthalmitis, retained lens material, uveitis, toxic endothelial cell destruction syndrome. So the most important step for preventing TASS is raising awareness. We know the etiological factors. If we know what all protocols we are supposed to follow, what all steps we are supposed to follow so that we prevent the TASS, that would be the ultimate cure for us in tackling the incidence of any TASS at any particular center. So for this, the TASS prevention protocol, it came into practice. And what is that? So here we'll have a look at the TASS prevention protocol. TASS prevention protocol, it gives you cleaning guidelines for surgical instruments. It develops content and schedule for routine training of surgical staff. It gives you regular surveillance of regional outbreaks of TASS, and it gives you annual review of new cases and update TASS prevention protocols. So whenever you come across any potential TASS case, that means if you have any unusual severe anterior chamber inflammation happening at the early postoperative period, first, you are supposed to share information with other ophthalmic surgeons using the same operating facility. Review for the recent surgical case log for any other possible TASS cases, and check for any recent changes to surgical materials, procedures, or OR environment, etc. If you find anything positive, you're supposed to shut down the operating room facilities and initiate a thorough investigation. Now, that thorough investigation will include your microbial cultures, for sterilization equipment, instruments, and phaco machines. You have to check the cleaning protocol for surgical instruments. You have to check for the disposable and reusable surgical materials, specifically OVDs, tubing, cannulas, IOL, BSS. And you should interview all surgical staff members to find any changes, deviations in the protocol. When you find any unusual anterior inflammation, as we have mentioned earlier, and the first differential being infectious endophthalmitis, we should always send for a microbiological study from the aqueous humor or vitreous tab to rule out any infectious endophthalmitis. If the culture comes out to be negative, then look for the regional outbreak of TASS. If you find any, then you have to look for the source from where that outbreak has happened, and you're supposed to report to the TASS registry and share the information with your rest of the regional community. If you find it comes out to be culture positive, then you treat on the lines of infectious endophthalmitis. When you have shut down the operating facilities and initiated a thorough investigation, and you are able to identify the etiology, then corrective measures and have to be taken, and you have to educate the surgical staff. After that, you can start with your small volume of trial surgeries. And if everything is going well, you can probably go ahead with your regular surgeries. But if you find that in your close follow-up, still the cases of TASS are coming up, then you're supposed to again shut down the operating facility and initiate the investigation again. On the other cases, if you're not able to find out the etiology, then again you can start with a small volume of surgeries, and depending upon the response, if it goes well, then you can start with the regular OTs. And if you find that still the TASS cases are happening, that means you're missing onto something, and you have to again restart with the thorough investigation. So this is a very important TASS prevention protocol that must be followed in any suspected potential TASS case. It is very important for all of us to work as a team whenever such critical scene comes up. So the surgical team, it comprises operating surgeon, surgical nurses, operation theater technicians, and anyone participating in the preparation. They should work together and undertake a complete review of all the OR protocols. A careful investigation and elimination of all the possible causative factors combined with thorough management of all possible risk factors is crucial. The surgeon and staff at the center should carefully review all of the medications and solutions that are used during routine anterior segment surgery. The team involved in investigating should carefully evaluate any fluid solutions or medications used during the surgery and record all the involved lot and batch numbers for potential etiological agents. All cases, they need to be treated promptly and vigorously, along with open communication with the surgical facility to follow any local investigation and reporting procedures. We need to ensure that the fellow surgeons and colleagues are made aware of a TASS incident so as to identify and report any further cases. So as we all know, prevention is always better than cure. So what comes in primary prevention? Use of proper balanced salt solution with correct pH, osmolarity, and ionic composition. Avoid preservatives in intraocular solutions, intracameral medications, or irrigating solutions. Use of fresh ophthalmic viscosurgical devices. Adequate sterilization of instruments and tubing according to the manufacturer's protocol. Standard and clear operative and instrument processing procedures need to be implemented, and the staff and surgeon should be well aware of the SOPs. The American Society of Cataract and Refractive Surgery funded and established the task force to investigate and monitor any outbreaks of TASS in the year 2006. ASCRS, the American Academy of Ophthalmology, and the American Society of Ophthalmic Registered Nurses have also published guidelines on how to clean and sterilize intraocular surgical instruments to prevent TASS. As you've already seen in previous slides, that the surgical instrument cleaning is utmost important because that is the most common cause which leads to TASS. And these guidelines, they're easily available for all members for the surgical team to access. So what are these guidelines? Just have a look at them. There should be proper flushing, cleaning, and autoclave sterilization of all surgical instruments. There should be separate cleaning and sterilization for ophthalmic instruments from other surgical instruments. Instruments that need to be reused, such as phaco and irrigation handpieces, they should be thoroughly rinsed at the end of each case with sterile deionized water through both the irrigation and aspiration ports. There needs to be regular replacement of the fluid on a daily basis in any ultrasound or water bath, which is used to clean instruments, because it may get colonized with gram-negative bacteria, producing endotoxins that are heat stable and which cannot be deactivated by autoclaves. The enzymatic determinants and other active ingredients, they must be removed from surgical instruments by using sterile water jet under pressure if it is being used. We need to ensure that the inside of the autoclave is cleaned and the water reservoir of steam autoclave sterilizers is changed at least weekly, so as to prevent the accumulation of any potential toxic residual material and the buildup of gram-negative bacteria with lipopolysaccharide endotoxins. Instruments with lumens, they should be dried with forced or compressed air after thorough rinsing. Proper BSS with correct pH, osmolarity, and ionic composition should be used. The safety of the dye agents used for anterior capsule tanning should be ensured. The intracameral drugs like epinephrine in the irrigating solution and intracameral lidocaine should be used without preservatives and in proper concentration. Appropriate concentrations and dilutions of intracameral antibiotics should be used. Use of fresh ophthalmic viscosurgical devices needs to be encouraged. IOL tips, cannula tips, and the surfaces entering the anterior chamber should not be touched with a gloved finger, as both powdered and powder-free gloves can cause TASS. The recommended procedures for cleaning and sterilization of the instruments should be adhered to the manufacturer's direction for, and that should be followed. Here is a list of TASS outbreaks which happened from the year 2015 to 2023. In the inciting agents vacancy, it ranges from dye to intracameral pilocarpine to gloves to silicone oil to contaminated IOLs, drops, and the ointments. And it involves almost all procedures ranging from cataract surgery to ICL implantation to vitrectomy to even the intrametal injections. So it can practically happen with any of the consumers we are using, any of the medication we're using. It can happen almost with any of the surgeries which we perform on the daily basis. Now, this is very important for us to know the difference between TASS and infectious endophthalmitis. And as I mentioned, that this is the first and prime differential diagnosis of TASS is the infectious endophthalmitis. So here is the chart which gives you the differentiating features between the two. In patient of TASS, as we said, patient may have absence of pain or may present with mild pain, and in few cases they may also present with severe pain. But in infectious endophthalmitis, mostly the patient is present with moderate to severe category of pain. As far as inciting event is concerned, they're typically occurring within 12 to 48 hours of any kind of anti-segment surgery. So the onset is happening in case of TASS within 24 hours. In infection endophthalmitis, it can also occur within 12 to 48 hours, can range even to 4 to 7 days. The important thing to note here is that if we talk about the corneal edema in cases of TASS, it happens from limbus to limbus, and it really happens in patients presenting with infectious endophthalmitis. Pupil may be fixed and dilated because of the iris ischemia in cases of TASS, but in infectious endophthalmitis, patient in the initial stages usually present with a reactive pupil. If we talk about the extent in TASS, it almost always limits itself to the anterior segment. And when we see the presence of the inflammation going to the posterior, we should err more towards the infectious endophthalmitis. Culture, as we said, it will always be negative in cases of TASS and mostly positive in cases of infectious endophthalmitis. If we talk in terms of response to steroid, TASS will give a beautiful response with steroids, whereas infectious endophthalmitis may initially show you good response, but ultimately worsen if you only treat it with steroids. Suzuki et al. Has described a TASS outbreak with a mean of 38 days until presentation that involved posterior segment with minimal vitreous opacities in 21.5% of the patients. Whereas Miyake et al. Reported 6 cases of TASS that developed between 42 and 137 days after the cataract surgery. So these are the exceptions. Usually they are presenting within 12 to 24 hours of any anterior segment surgery. If we come across any presumed endophthalmitis case, then anterior chamber aqueous tap and vitreous tap or biopsy is planned, and the material is sent for complete microbiological testing, which includes PCR for eubacterial and pan-fungal genome. Real-time PCR is a valuable diagnostic tool for rapid diagnosis of bacterial endophthalmitis with higher sensitivity than routine bacterial culture. So we have seen the prevention part. Now we ultimately come to the treatment part. If the patient has presented with mild signs, then topical potent steroid is the mainstay of treatment. You can either give prednisolone acetate 1% or dexamethasone 0.1% in a frequency of 4 to 8 times. To add to the limited effect of topical steroids, you can also add subconjunctival dexamethasone. If the patient is presenting to you with severe signs, that means there is a presence of fibrin or the patient has present with hypopyon, then you have to add oral steroids. You can add oral prednisolone of around 40 mg. Topical NSAIDs can also be added to control the pain. As we have said earlier, if the patient is presenting with severe signs of anterior segment inflammation, specifically in terms of hypopyon, then always err towards infectious endophthalmitis. So addition of broad spectrum antibiotics like moxifloxacin is advisable whenever you come across severe case of TASS, as 30% culture turns out to be negative. You may have cases who may not respond to steroids as you expect. So in those cases, you can think of giving recombinant tissue plasminogen activator in the concentration 25 microgram per 0.1 ml intracameraly. It helps to dissolve fibrin and has shown its efficacy in around 80% of cases, as shown by Doughton et al. Close follow-up of such cases for inflammation, IOP, and corneal condition is recommended. If you do not find the adequate response or you find the condition is worsening despite giving steroids, then repeat the culture to look for infective cause. It's important to do thorough gonioscopy to rule out any missed lenticular fragment that may be leading to the severe anterior segment inflammation. Besides giving this medical treatment, some patients may require surgical management. So surgical intervention may range from AC wash to anterior vitrectomy, vitrectomy with or without IO removal. Ohika et al. And Suzuki et al. Has reported 29.3 and 43.4 of TASS cases which required surgical intervention. AC washout may be required if there is a persistent corneal edema. Duane et al. Has reported that AC washouts can be performed in patients who develop steroid-responsive glaucoma with eye stents placed intraoperatively to help control the pressure while you continue the use of topical steroids. Even despite giving the treatment for secondary glaucoma, some patients may require glaucoma surgery too. Avoid giving prostaglandin analogs. In cases of severe TASS with irreversible damage showing marked corneal edema and a residual chronic anterior segment inflammation, there may be a need for corneal transplantation. Endothelial keratoplasty techniques like Desmet's membrane endothelial keratoplasty and Desmet's stripping automated endothelial keratoplasty have replaced penetrating keratoplasty as the procedure of choice. Now, what can be the possible complications in cases of TASS? Mild cases of TASS, they usually resolve without any complications. But irreversible corneal endothelial damage and decompensation, in cases of uncontrolled severe TASS, they may require corneal transplantation. And we have seen in previous slides, endothelial keratoplasty is an effective way to replace decompensated corneal endothelium after such cases. Kaur et al. Has reported that the time interval between TASS and endothelial keratoplasty is critical for successful surgical outcomes. And in the report, a time interval of less than 3 months has resulted in high rate of graft failure, while its time interval more than 3 months resulted in 100% successful outcomes. If the patient is having secondary glaucoma following TASS, then besides anti-glaucoma medications, glaucoma surgery may be needed. Patients may have complications like cystic epithelial downgrowth onto the Descemet's membrane. Patients may have inflammatory deposits on the iris, which may lead to dilated and fixed pupil. Patient may have iris ischemia, iris atrophy, pupillary distortion, and poor pupillary dilation. And chronic cystoid macular edema may be the complication seen in such cases. So if we talk about the prognosis of TASS, the prompt diagnosis and initiation of appropriate treatment that determines the prognosis of TASS. Sengupta et al. Has reported that 58 out of 60 TASS eyes achieved a best corrected visual acuity of 6/9 after 1 month of treatment. However, eyes were complicated by atrophic iris in 24% of cases. Posterior capsular opacification was found in 16% of cases, severe anterior capsular phimosis in 12.5%, and chronic and cystoid macular edema in 4% of cases was seen after 6 months after the treatment. TASS, if it's happening secondary to the use of intracameral agents, it shows poorer prognosis. So in the conclusion, whenever TASS is suspected, a thorough investigation of possible etiology is critical, as is sharing the information with your colleagues. TASS can occur anytime and unexpectedly. TASS is mostly preventable by the establishment of TASS prevention protocols, regular training, and thorough adherence to recommendations for cleaning and sterilizing intraocular surgical instruments. These are my references for the presentation, and thank you so much for your patience here.
Thank you, ma'am. That was a very lovely and complete presentation. I would like to invite the chairperson, Sir Gaurav sir, and Dr. Prafulla sir, moderator sir, for their expert comments.
Thank you, Dr. Lakshmi. That was a wonderful talk. We must almost covered the entire spectrum of TASS. And from students' perspective, TASS can come as a short note in your theory exam. From practical point of view, it's very rare that you'll get a short case on TASS. However, corneal decompensation as a complication of TASS can be given to you in exam as a short case. So from practical as well as theoretical point, TASS is a very important topic. And more than that, for real life scenario, you must have, all of you must have remembered few months back, we had an epidemic of TASS, right? And a lot of things were discussed, presented. When there was an article in IGO, in those time also we published something. So TASS is a very important topic because once you have operated a cataract patient, as the patient is expecting 6/6 and suddenly vision is low. And then it's difficult, very difficult for a surgeon to explain to the patient what has gone wrong. The most unfortunate part is, I think Dr. Lakshmi would agree with me, most of the time the etiologies cannot be identified. Now, these are, you can guess maybe because of this, maybe because of that, but most of the time it's very difficult to pinpoint on one etiology. Dr. Lakshmi, from students' perspective, I would like to ask you one thing. If there is a TASS, what would be the ideal steroid protocol? How
Ideal
long would you
steroid
like to
protocol, sir?
continue? What is the steroid
Ideal
protocol for a
steroid protocol. Yeah. So whenever the patient is presenting on the first day, as you have rightly mentioned, it's a very point of concern for all of us. So if the patient is present with mild signs and symptoms, where the visual acuity is, I would say maybe around 612 something. So we are more dealing with the cases of TASS unless you have a very strong fibrous reaction in hypopyon. Then I usually prefer giving prednisolone 1% acetate to such patients. And I also give coverage for topical antibiotics too. So most of the patients, they have done well. But if the patient, I find that despite giving the treatment, they are worsening or the vision is dropping down, I usually, every day I follow them up. So I don't have the facility for IP admissions, but I usually call them in the OPD every day. And I find that if they are dropping down, the vision is dropping down, and if the segment inflammation is increasing, then I prefer to err on the side of infectious cell, like that is a dreaded complication which should not be happening. And then I prefer to take the aqueous tap. I don't straightforward go to the vitreous tap because most of the time the aqueous do the work for us to give the idea whether the patient is having any kind of a bacteria which is running inside, maybe causing the issues. And if that's so, then we move on to treatment in terms of the infection endophthalmitis. But usually the prednisolone 1% acetate, that has done well in my hands.
How long will continue that?
Sir, I usually give it for a week first. I usually follow, if the inflammation is high, I usually give 1 hourly for 2 to 3 days. Then I taper it down to the 8 times. And after a week, I see if everything is going well. Then on a weekly basis, I start tapering it down. Usually it runs maybe period for 3 to 4 weeks at the max. Not more than that I've given it.
But yeah, true. So most of the cases of TASS they resolve, but there are few cases, where there is some slow ongoing inflammation goes on, and the patient presents with TASS later on. That just to tell you one example, one of my patients, he was referred from Kashmir with the diagnosis of TASS, and it was an irreversible corneal edema consequent of TASS. So we registered for DSEC, and once when the turn came for that kid, he came back after 6 months, and by that time his cornea was edematized. There was 360-degree patch. So only fault was that the treating physician there, because I asked him to follow up with the original physician, the actual physician who was looking after it. So he stopped steroid. The moment we registered for DSEC, the patient steroid was stopped, and the progressive inflammation that led to entire damage to the entire segment. So I think let's take opening from our chairperson for today also. What is Dr. Gaurav? What's your take on that? What should be the ideal protocol for patient?
Very difficult for us to actually differentiate the first.
So you're not audible.
Am I audible now?
So
Yes,
please
sir.
move closer to the mic, sir.
Yeah, better now. What is better now?
So voice is breaking.
So let me continue till his audio improves. So ideal situation is you titrate depending on the inflammation. And if inflammation is persisting, it's always good to continue steroid for a long time. But as Dr. Lakshmi said, most of the time within 4 to 6 weeks, usually the patient, usually they improve without any inflammation. But at times it may prolong, it may be there for a prolonged period of time, and then all the complications that can trouble the surgery. Yes, Dr. Gaurav.
Yeah, am I audible now?
Yes, sir.
Yes, sir. You are audible.
Good. So I want to add that like when you're sitting in a clinic, it becomes very difficult for us when the patient comes on the first post-op day, whether it's TASS or in fact, whether it's endophthalmitis. So whenever I am there, I have a patient who has TASS or who has increased inflammation on the first post-op day. I always consider that patient to be a patient of endophthalmitis. So we give a cocktail of medication to such patient. We give them antibiotics, topical antibiotics. I may or may not give him oral steroid, but we give cocktail of antibiotics plus steroids. If you have a retina facility available and you can do some surgical management, or you can take a culture, which is theoretically said, ideally we should be doing, you can do it, but sitting in the clinic, a lot of time it becomes very difficult for you to do the culture in the first go. You have to see the patient clinically and see how it's improving or deteriorating, and then on the second day or the third day, decide whether it's TASS or maybe endophthalmitis.
And also, it's very difficult to counsel patient for a second intervention on day 1 or day 2, like if you are planning a biopsy or a CTAP, at times the patient may not agree with you, especially in practice.
Right,
And so
patient.
even so, when the eye is inflamed and we already don't want to unnecessarily prick into the eye, you may inadvertently, in fact, convert a TASS into an infectious one. So
Yes.
rather, I think first start with the steroids and let's see how the response comes with a close follow-up. And we always have the facility to go into the aqueous to have a TAT later. So I think a close follow-up and taking the decision should be mindful that you should not straightway jump into taking the aqueous type right on the first or the second day. That's what my take on this.
I agree with that. You should, with the steroids, I think you should give a lot of antibiotics to the patient as well.
True.
The steroids under a cocktail of antibiotic cover, covering both the gram-negative and the gram-positive.
True.
So there are 3 important viva questions here that were just discussed for today. One, it's a very common question: how do you differentiate between infective endophthalmitis and TASS? So rapid response to steroid, as Dr. Lakshmi pointed out, start with 2 RE. If significant improvement is there, that's most likely it's a TASS. And the second, Dr. Gaurav pointed out that endophthalmitis usually rare on day 1, and it's a very favorite question among senior faculties. So anything that presents within 48 hours may be endo, but within 24 hours it's very rare to get endophthalmitis. I think Dr. Lakshmi highlighted in the table how to differentiate. So these are the 2 important viva questions that is often asked to. And third is limbus corneal edema. It's very characteristic of TASS, which is not there in endophthalmitis. I think, am I right, Dr. Lakshmi? These are the telltale signs that help you in differentiating.
Absolutely.
What about IOP? That is also an important point.
Yeah,
IOP is usually raised in TASS.
Yes. So I would say even the endo patients also, they even also present with moderate to, I would say moderate side of IOP, but usually at the present, they don't even present with a very high IOP. So I would say alone just
some
giving
features
IOP.
Are overlapping.
Sorry, sir?
I think there are some overlapping features, but limbus to limbus edema and rapid response to steroid.
Yes,
these are almost certain.
True. And even I think visual acuity, if it is like significantly down, then we should err towards more of infectious as compared to the TASS. Just like maybe around the counted fingers or around hand movement, that maybe you're dealing with more of an infective pathology.
But as Dr. Gaurav said, even if you are suspecting TASS, always rule out infection.
True.
Any questions, Garvita?
Yes, sir. We have some questions from YouTube, sir. First question is, TASS, what is the practice regime of management? Are oral steroids any beneficial?
Dr. Lakshmi, would you like to take that? Oral steroid.
Oral steroids, I think we are just discussing the same thing only, that first start with topical, because we are seeing it as an anter-segment inflammation. And if the patient is responding well and the patient is present with mild symptoms, then we usually don't have to start with the oral steroids. But yes, if there is a significant inflammation for the anter-segment, then as Dr. Gaurav sir has slightly said, that we have to err more towards infectious. So because inflammation, if the eye is too much inflamed, that itself is going to cause harm to the eyes. Just leave apart the infective pathology part. So we have to take care of the infection as well as the inflammation. So in those cases, when you start with the antibiotic coverage, you have to give oral steroids only if the patient has a severe signs and symptoms at the time of the presentation. But for mild cases, I usually won't prefer to give for the oral steroids.
So from exam point of view, whenever possible, we prefer topical steroids only. So if the examiner asks you, would you give oral steroid? The answer is no. Unless there is massive inflammation that is not being controlled by topical steroid.
Right,
sir. Oral steroids is something which I'll give only when the culture or maybe the TAP has come out to be negative for the patient.
Yes.
Orals, I will not prefer oral steroids in such patients.
Gaurav, what is your take on if you have come across any fungal errors and fungal endo cases? Because we don't give intravitreal steroids in that cases, but what is your take for the oral steroids in that cases? Do you prefer to give, or you stay away from steroids in any fungal cases?
It depends. If the inflammation is very, very severe, then topical steroids work well on your fungal end off as well. But it's for oral steroids, I will still err on it. I will not prefer to give oral steroids.
Okay.
Even that is what,
In fungal end of,
although
in
I'm not a
fungal end of
retinal
format.
surgeon,
Intravitreal is a complete
uh,
no, so we don't give intravitreal, absolutely no in fungal. But I think oral steroid has still as a controversial. Some prefer to give, some still stay away from giving steroids in fungal cases.
yeah, although I'm not a retinal surgeon, but I have seen a few faculties at RP Center. When I don't know, I think Dr. Gaurav may correct me. If the chances of retinal necrosis is very high in fungal end off, they do give steroid.
I think
Otherwise, they usually avoid.
Yeah, I think it's depend actually on the retina surgeon. Plus, it depends very subjective. According to the patient, that the patient has what kind of systemic disease the patient have, is diabetic, non-diabetic. Depending on that, also you will depend. I'll consider whether I'm going to give oral steroids or not.
Garvita, any further question?
Yes, sir. I have more questions. Does TASS depend on patient's reaction more than the etiology itself? This is from YouTube.
Dr. Lakshmi?
Depends
Would
on
like to take
patient
that?
reaction.
Yes,
Sorry, I
ma'am.
So
didn't
the
get the
question
question.
is
Patient
whether the
reaction.
task is primarily a patient reaction rather than the etiology.
Itself, the body is producing, what I get from the question.
Yeah,
If
yeah.
patient is
Just like,
if patient is diabetic, or if patient is having systemic illness, then definitely that's going to add on to the increased possibility of developing TASS. And definitely, if not patient is uh, not taken, before surgery, the proper bath is not following the proper cleansing, then obviously that may lead to the issues. But as such, is most of the cases it is said that it is the etiological factors, as either because of the consumers which are using intraocular, the materials which are using, or it's because of the surgical instruments or the powdered gloves. But yes, patient factors, they play a role. If the patient is uncontrolled diabetic, having systemic issues, then definitely it plays a role in it.
yes, definitely. If you people remember your pharmacology reading, right? There is a field called pharmacogenomics. So whichever disease, whichever reaction, whatever you are getting in your body, somehow the patient's own factor are also responsible to that. So you can say somebody is having a mild form of task, somebody is having severe form of task with the same etiology. Then there comes the patient's reactivity that comes into play. So definitely some patient factor is there, but it is usually incited by some etiological agents which Dr. Lakshmi has already enumerated in the talk.
Should I continue with the next question, sir?
Yes, please.
What are the precautions preoperatively that can be taken to prevent TASS as beginner surgeons?
I think Dr. Lakshmi enumerated all these points, right? Profile prevention.
TASS, as we say, sir, it is just only related with the systemic issues. So it has to be a good control of blood sugar and the systemic issues, as we have said. But and proper cleaning, though it will lead more to the infectious. If the patient has not taken bath, and if he's not taken a head bath before the surgery is proper, not cleansed, that will err more towards infection, not for the TASS. But yes, there has to be a good systemic control before we plan any kind of surgeries for the patient. And as we have said, there has to be a full protocol, as I just mentioned in the slides, how the surgical they should be properly cleaned up. You're supposed to use the proper pH and osmolarity of the intracameral usages of drugs. OVDs, they should be fresh. The blades and everything, your eyes. So all we have a huge list they have given. So that has to be taken care whenever you plan for a surgery.
As a beginner, you should have SOPs for everything, right? And in your OT, just take a printout and paste it and let the sister follow all the SOPs. Because most of the time, instrument cleaning, everything is done by the nursing officer or your sister in charge or OT technician. So they have to be aware what all things can lead to that.
SOPs are very important. So that is why the SOPs are made, so that the whole, as we said, like as I mentioned, it's a team. So we just cannot leave everything on the person, because you are surgeon. So we have to see that what the nurses are doing, what the technicians are doing, because the onus is on us. So we have to be aware that what other people are doing, and we have to make SOPs so everybody follows, so that we can prevent these cases from occurring.
Last question, ma'am. What has been your experience with TASS, ma'am, in your practice?
Thankfully, I have none of my case had developed TASS, but I've seen other people who just came as a follow-up for the TASS. And I've seen cases of infectious endophthalmitis. As I said, if there is a very mild inflammation, which may occur maybe because sometimes it happens during the per-op area, the iris touches, that also get inflamed. So the next day you see a lot of reaction. Sometimes the endothelial gets decompensated because the beginners, they are doing the surgery. Then also you see the edema on the next day. So that's fine. Matlab, a slight of inflammation, I give steroids, they do well. And hardly I've just come across so far just 1 or 2 cases. And endophthalmitis also, luckily, I've just only come across 4 cases and touch with none of mine cases. So I would say like I've not come across much of the cases for the TASS and infectious endophthalmitis of my operated cases. But the
Early
only important
diagnosis
thing
is
I
very
always
important.
point out that consumers, they have to be fresh. Because what I found that whenever the problem is occurring, that happens whenever we try to reuse the things. That's what I found in most of the cases. Because we try to basically as a cost cutting, we just try to divide the stuff in multiple patients. So I think that is the most common issue, which is leading to TASS and all these issues. So if we are able to curb that practice, if we are able to at least use a fresh material for every patient, I think it will come to a much, much, much lower incidence level.
Instrument, also the cannulas. Most of the system keeps on reusing those cannulas for BSS.
Absolutely.
Or viscoelastic. They use Hilot cannula for BSS. So that has to be cleaned properly. At times when you inject something, you will notice some white material is coming out of that cannula. So all these things you have to train your OT staff to do this thorough cleaning part of your instrument.
Those were all the questions, sir. So one more question that has popped up on YouTube. What is the role of subtenon injection of triamcinolone in TASS?
Triamcinolone, I usually topically is doing well. You can give subconch DEXA. You can give PSTs also if the inflammation level is really high, or if you find that only the topical steroid is not doing that well. But again, you have to be very, very careful that you're not missing onto the part of the infectious part. So just a close follow. And if you find that despite even giving the topical, the reaction is not settled as up to your expectation, or if the vision deteriorating, then please move on to the treatment on the infectious part after a thorough investigation. So just by giving PST, just don't sit happy that we are actually dealing with TASS only. So because you have given a depot of these steroids over there, so you have to be extra careful that now it has to be very, very close follow-up, very diligent follow-up of the patient.
Very true. Without ruling out infection, don't put any depot of steroid. So then your life will be difficult if you land up in a fungal end and you have already a PhD there. It's going to make things really worse for you.
And
if
it comes out to be fungal, then sometimes you have to even take out the depot and you unnecessarily make your life hell, just to add to the added benefit. And you've injected, and probably if you find that it is going into the wrong direction, you simply have to take it off also. So that again, unnecessary intervention you've added on to.
For students, TASS is not vitreous inflammation. It's mostly intersegment inflammation. And most of the steroids, those are available in market, they have very good penetration. So no need to go for all these things.
So the patient, if it's a steroid responder, then you're in a much more soup.
Again,
then you're dealing with 2 pathology at the same time. Glaucoma plus your TASS.
Garvita, I think you'll have to conclude.
Okay, so there's no more questions, sir. Check twice. And thank you for everyone for the wonderful session. Thank you, Dr. Lakshmi ma'am, for a great class. Thank you, Dr. Gaurav sir and Dr. Prafulla sir, for your kind comments and expert inputs. Thank you so much.
Thank you so much. Thank you.
Thank you. Good night.